Good morning and afternoon for some of you, and welcome to today's webinar on heart monitoring and cryoablation treatment for atrial fibrillation. I'm Melanie Trujillo, the founder and CEO of StopAfib.org, which is a patient advocacy organization, and I'm honored to be the host and moderator for today's webinar. As you know, September is Afib Awareness Month, and living with Afib can be challenging, but the more you know about your Afib, the better you can partner with your physician in making decisions regarding your care. So our goal for Afib Awareness Month is to bring attention to this life-altering condition and to help people living with Afib to learn more about it. So thank you to Medtronic for hosting this important educational webinar for Afib Awareness Month. We have an exceptional speaker today, Dr. Ilana Kutinsky, an electrophysiologist from Beaumont, Michigan Heart Rhythm Group in Troy, Michigan, and a special guest speaker, Terry, who's one of Dr. Kutinsky's Afib patients. But before we begin, we have a few housekeeping items. If you'd like to expand your viewing page, you have two options. You can select the three dots or three stripes at the top right of your screen for a drop-down list. Within that drop-down list, you'll find a row called Zoom. You can click on the plus sign to make the screen bigger or the minus sign to make it smaller. Or if you'd like the viewing box to be full screen, you can click on the icon at the bottom right of the viewing box. And then to revert back to the original screen that you see now so that you can submit a question, click Escape at the top left of your keyboard. If you have questions during the webinar, please submit them in the Q&A box on the right side of the video window. We'll try to answer them during the webinar, and if a fuller answer is needed or we run out of time, it will be answered later via email. Also, please know that we're recording today's webinar. On the slide, please take a moment to notice Dr. Kutinsky's disclosures. We also want to remind you that the results described in this presentation are unique to these patients. So not every patient responds the same and results may vary. Always talk to your doctor about your condition and the risk and benefits of Medtronic products and treatments described in this presentation. And lastly, this presentation was developed for a U.S. audience. Not all devices and treatments are approved for use in all geographies. So now, please let me introduce today's speaker, Dr. Ilana Kutinsky. Dr. Kutinsky has been a practicing electrophysiologist for just shy of 20 years. She graduated from medical school at Michigan State University and pursued her cardiology and electrophysiology fellowships at the University of Colorado Health Sciences Center in Denver. She made her way back to Michigan and is now with Michigan Heart Group associated with William Beaumont Hospital in Troy, Michigan. A special passion of Dr. Kutinsky is her role as the co-director of the National Great Ape Heart Project, where she takes her cardiac expertise to the care of apes. With that, let me turn the floor over to you, Dr. Kutinsky.
Hi, everybody. I'm Dr. Ilana Kutinsky, and I am your guide on today's educational visit through atrial fibrillation. So thank you so much for having me, and thanks StopAfib.org for moderating, and thank you Medtronic for sponsoring this. I think it's really exciting, and hopefully we get lots of good questions. So I am an electrophysiologist who specializes in abnormal heart rhythms. So my job is to take care of patients who have atrial fibrillation. So we're going to talk a little bit about atrial fibrillation and hopefully educate you on where it comes from and why it's a problem. Then we're going to talk about how we find atrial fibrillation or document atrial fibrillation with heart monitors We're going to talk about different atrial fibrillation treatments. And then you get to talk to Terry, my patient, who is on, and hopefully he can kind of give you some kind of tips on the experience and what he's been through. So let's talk about atrial fibrillation. It's a huge, huge medical issue. There are 16 million people that they think by 2050 that 16 million Americans will have atrial fibrillation. Right now, I think it's about 6 million, depending on what you look at. So 6 million people in the United States, and by 2050, 16 million people. It's a lot of Americans are going to have atrial fibrillation. It's not just a problem here in the United States, it's a problem all over the world, but most of our research has been from the United States, and so we're going to kind of focus on that. In your lifetime, if you have atrial fibrillation, it becomes a real risk factor for other problems. We know that it increases your risk of stroke, probably close to 5 times higher risk of stroke if you have atrial fibrillation, increases your risk of heart failure 3 times, and increases your chances of having a heart attack. And actually, this is something I recently found out about. It increases your risk of dementia. And if that's not a good enough reason not to have AFib. What is atrial fibrillation? Let's talk about what it is. It is an irregular heart rhythm that affects the upper chambers of the heart, and it decreases the chances and the efficiency of how the heart works. So if you look at the picture in the upper right-hand corner, you can see a picture of the heart and the normal electricity going through the heart. So the heart is made up of 4 chambers. You have the atria, which are the top chambers of the heart, and the ventricles, which are in the bottom part of the heart. The right side of the heart takes blue blood from the body, so blood that has given away its oxygen, and it's blue. It comes into the right side of the heart. The right side of the heart pumps blood to the lungs. The lungs fills that blood with oxygen. It becomes red blood with that juicy oxygen, and that gets dumped into the left side of the heart. Then the left side of the heart pumps the blood to the body. The first place that goes is to the brain, which is why there's such a big connection between the heart and strokes. And we're going to see that come back later in our talk. But this electrical system is very well organized. You have electricity that starts in the top part of the heart and transmits through the heart in an antegrade manner, so going forward through the heart, and then the heart beats. So the electricity goes through the heart and the heart beats. What happens in atrial fibrillation is you have these little chaotic little electrical impulses that come from an area of the heart called the pulmonary veins. Pulmonary veins are an area in the back of the left part of the heart where the blood from the lungs drains into the heart. And where that happens, you have disrupted electricity. When that disrupted electricity gets into the heart, it causes atrial fibrillation. If left untreated, like we talked about, atrial fibrillation increases your risk of stroke, heart failure, and even dying from atrial fibrillation. What we do know is atrial fibrillation can also impact your quality of life, your energy level, and what you can do. How do you know if you're having atrial fibrillation? Well, I mean, the symptoms of atrial fibrillation are varied. You can sometimes feel irregular, rapid heartbeats. So you might feel fluttering or pounding in your chest. You may be tired. You may have shortness of breath, or you may just not feel like you can do the things that you usually do. Remember, the efficiency of your heart is less when you're in atrial fibrillation. Some people have pain, chest pain, and some people complain of dizziness. But what's super important, and I hope that everybody takes home from this webinar, is that over 39% of the time, people have no symptoms. So you can present to your doctor's office for a routine visit, and they can do an EKG or they can listen to your heart and find that you're in atrial fibrillation. And so there's a lot of people walking around with atrial fibrillation that they don't even know of. And in those patients, a lot of times the very first symptom is a stroke. So what kind of things cause atrial fibrillation? Well, I think that first of all, you have to have those abnormal electrical connections that we talked about in the back of the left atrium where the pulmonary veins are. So if you have to have those abnormal electrical connections, and those abnormal electrical connections are probably something that's genetic. So you have to have those abnormal connections, and then you also have to have something that triggers the episodes. Okay, so an enormous amount of a stimulant like caffeine or alcohol can do this. Lack of physical activity can do it. Some medicines, like any sort of stimulant, hypertension can do it. Other types of heart problems can cause it. High blood pressure can cause it. After a long period of time of having high blood pressure, it puts stress on the heart. That can do it. And sleep apnea is a big player. So one of the things that we always make sure that we go through this kind of list of other things, other lifestyle changes that people can do. And sometimes by improving things in your lifestyle, with your lifestyle, you can decrease your chances of having atrial fibrillation. So atrial fibrillation is a progressive disease. I think it's very important to remember this. So atrial fibrillation starts with these little bits of electricity hitting into the left atrium and bouncing around and causing the chaos in the left atrium. The more atrial fibrillation you have, it becomes more persistent. Like there's a saying, atrial fibrillation begets atrial fibrillation. And so the longer you have atrial fibrillation, the harder it is to manage the atrial fibrillation. The kind of alternate of that, or the associate of that, is that the sooner we can treat atrial fibrillation, the more successful we are at terminating it or controlling it. These are different things. So there's lots of different ways to treat atrial fibrillation. You can treat it with medication. There are antiarrhythmic drugs that we can use to treat atrial fibrillation. We can do something called cardioversion, which is an electrical shock to the heart. We do that while you're sleeping. And even though it sounds fairly barbaric, you know, when you watch a movie or something, you see somebody with the paddles, and we don't really use paddles, we use patches. And it's a very controlled procedure to reset the heart electrically. We can put in pacemakers or defibrillators for arrhythmia problems like atrial fibrillation, and we can do something called catheter ablation. What catheter ablation does, and we're going to talk about this a little bit more, is to disable the unwanted electrical signals in the heart tissue. And then there's surgical ablation, which also does what we do with catheter ablation, but with open heart surgery or with surgery. So to treat atrial fibrillation, there's a lot of goals that we have. And obviously you want to talk to your doctor and discuss so that you come up with a goal and goals that you both agree on. But for me, for my patients, I want to relieve symptoms and improve quality of life. We want to prevent blood clots and decrease the risk of stroke. We want to control the heart rate, allow the heart to become more efficient. We want to reset the heart chamber and allow the atria and the ventricles to work together efficiently. So how do you find atrial fibrillation if you don't have symptoms? So a lot of patients are going to present with symptoms. They're going to have irregular heartbeats. They're going to be short of breath. You may feel lightheaded or tired. You may not be able to walk up a flight of stairs. You might not be able to walk your dog. And then, so you would present, but what happens if you don't present? What if you're wearing your Apple Watch and you get a reading that says atrial fibrillation? But we need to have a way of monitoring atrial fibrillation. So we have all these different ways of monitoring. There's watches, right? There's consumer products that you can buy on Amazon that you can test yourself at home and look for atrial fibrillation. This has all happened in the last 3 years, and it's pretty remarkable, and it's revolutionizing how we can identify it in your home. If you go to your doctor and you're having symptoms, they may have you wear a Holter monitor. A Holter monitor is a monitor with wires that they put on you, or a patch, and it records your heart rhythm. Obviously, you have to be wearing the monitor in order for it to catch the atrial fibrillation. You have to be wearing the watch to be able to catch the atrial fibrillation. All of these types of monitors have to be worn, right? If you're not wearing the monitor, you're not catching it. If you have a symptom record, like an event recorder, that goes by symptoms. If you're not having a symptom, You're not going to record the event. So what do you do in a patient who you're looking for atrial fibrillation, but they don't necessarily have symptoms? And that's where the implantable cardiac monitor comes in. So we're going to skip over these. Those are the consumer monitors, and we're going to talk a little bit about insertable cardiac monitors. So these insertable, this is a really interesting slide. If you look at this slide, you can look at 24-hour monitor. This is on this axis, you can see how much atrial fibrillation a patient has. And on this axis, you see these different ways of monitoring for atrial fibrillation. So if you see 24 hours catches less than 5% of atrial fibrillation, and then if you go to 7 days, still less than 5%. If you go to a 30-day monitor, maybe a little bit over 10%, close to 12%. If you do a 48-hour monitor every 4 months, you'll catch close to 10%. We have monitors now that people can wear for 30 days. Those monitors catch, still not so much. They catch about 15% of the atrial fibrillation that patients have. So when you compare those to a continuous monitor, so let's say a pacemaker, somebody who has a pacemaker implanted, that gives continuous monitoring. Those patients, you're going to pick up a lot more patients, about 85% of those patients, when you have continuous monitoring. This is another way of looking at continuous monitoring. So if you have a monitoring period and you have episodes that you feel and episodes that you don't feel, right? The episodes that you feel, a lot of times those aren't atrial fibrillation, and the episodes that you don't feel are atrial fibrillation. So how do you reconcile that? You need a monitor that's going to continually follow your heartbeat. And so what's been developed is a monitor called an implantable cardiac loop recording device. And this, there are several different kinds. This is one of the kinds. And what it has is like a little EKG that's inside of it. And it gives you a constant EKG all the time, constant telemetry. So it's always watching what your heart is doing. We are able to set these devices to take a look and watch for atrial fibrillation. And when it sees atrial fibrillation, it alerts the doctor that you're having it. And so this is pretty amazing, right? This is the best way to put in, to monitor for someone who doesn't have symptoms, or somebody who presented first with a stroke. And we're looking for why they had a stroke, and we think maybe they had atrial fibrillation, but they don't feel anything. So a lot of times we find atrial fibrillation when we implant these recording devices for stroke. And I think we have a little video that you can watch. There we go. So what happens is we recognize where the heart is, and we inject the little recording device. So this is the skin. These are the ribs. It's kind of a cool video. We make a tiny little incision, almost like a puncture wound. I think of these like, like old-fashioned depot shots that they used to give patients. And then you inject the recording device over the heart, and it's just under the skin, so it's not invasive. We remove the device that places the loop, and then the patient goes home. These devices have batteries that last up to 5 years. So for a patient who doesn't have symptoms, or we're trying to monitor for atrial fibrillation, I think this is a great option. It's a really great option. It's something that I use a lot for patients pre and post to help manage their atrial fibrillation. So let's talk a little bit about catheter ablation for atrial fibrillation. I think talking about medicines is beyond the scope of this. So we have about 5 more minutes. We're going to talk about catheter ablation. So if you look at the pictures on the right side of your screen, you can see the hole that has these devices going in are the pulmonary veins. Now, remember, if you go all the way back to the beginning of our talk, we talked about these pulmonary veins. Pulmonary veins are in the back of the left atrium, and the electricity from the heart is very organized. Where these pulmonary veins come in is there's kind of rogue electrical fibers that grow into these pulmonary veins that aren't supposed to be there. And that's where the majority of atrial fibrillation comes from. This says 94%. I always quote a little less, but this research said 94% of electrical activity comes from these veins. So remember, you have to have the other risk factors. So maybe you have sleep apnea, or maybe you have too much stimulant, or maybe you have done nothing wrong and you just genetically are predetermined to have atrial fibrillation. This is where the majority of it comes from. So what happened is that we found if we can isolate these veins electrically, it treats atrial fibrillation. And we don't like to say cures, because again, atrial fibrillation is a progressive disease, and in the future it may come back, but it manages your atrial fibrillation and it treats the atrial fibrillation very effectively. So how do we do that? How do we wall off the electrical signals from the back of the left atrium? Well, there are two ways of doing that. One of the ways that we do it is using radiofrequency ablation, and that is using electrocautery, which is like there's a little platinum tip, and we make little burns around the pulmonary vein. The other thing that we do is something called cryoablation. Now, cryoablation is an amazing technology that we're going to kind of talk a little bit more about. We have this catheter that goes into the vein. These catheters, both of them you see on both pictures, they show EKGs. So we can see when we put the catheters into the vein that there's electricity in the vein. And there shouldn't be electricity in those veins. So if I take a patient who doesn't have atrial fibrillation and I put this in their vein, there's no electricity in there. If I take patients who have atrial fibrillation, even if they're not in atrial fibrillation at the time, they'll have electricity in those veins. Then what we do is we blow up a balloon. The balloon then is inserted in the vein itself, or on the outside of the vein. So if you look at the vein itself and the balloon attaches to the outside of the vein, and then it freezes. And then everywhere the balloon freezes causes a freezer burn. And what we're looking for is a full thickness scar in this tissue. And what that does is it prevents the electricity from inside the vein to getting out. And it's really interesting when we have this catheter inside the vein, you can actually watch the electricity melt away. We do that in each vein, and that gets rid of the atrial fibrillation in most patients, that if we can get early treatment. Now, if we look at patients who were on that continuum, very far out of the continuum, kind of like permanent atrial fibrillation, this treatment may be used in addition to other things. So recently, when ablation started, we were using it in patients who we couldn't treat with medication. Now, we recognize that the earlier we treat, the better, and that early treatment with catheter ablation is super important in managing and kind of changing the natural history of atrial fibrillation. Cryoablation has recently been approved as an option as first-line therapy, even before medications. This talks about the research that showed that cryoablation was better than antiarrhythmic therapy in preventing recurrent episodes of atrial fibrillation at 1 year after the procedure. So now when a patient presents with paroxysmal atrial fibrillation, we can say to them, you can do either. We can put you on medication, or we can try an ablation. And ablation really does modify the natural history. It's really exciting that we have this as an opportunity. There's some more pictures like we talked about. This is the balloon. You can see the balloon going up and freezing. This talks about kind of what to expect before and after. You know, before the procedure, it's a surgical procedure. You're in the hospital for the day. We're currently sending most of our patients home same day. I think, Terry, you probably had to stay overnight. but most people now get to go home the same day. Okay, that's, I think, my time. We're right at 12:30. If you guys have other, obviously write your questions. This was supposed to be kind of like just a quick dive into some of the technology about monitoring, some of the technology about ablation. I'm sure everybody has questions, and I think that's where I'm going to leave off. And now we can hear from Terry.
So, Dr. Kutinsky, thank you so much. That was an excellent presentation. So now we're going to turn the floor over to Terry, our special guest, who's one of Dr. Kutinsky's patients. So Terry, thank you for joining us and for being willing to share your experiences about living with AFib. So let me turn the floor over to you.
Okay, my name's Terry Albrecht, and I'm a patient of Dr. Kutinsky's. And the way I found out I had AFib was I went to Beaumont. They offered a series of tests. It was called a 7 for 70. And for $70, you got 7 tests and blood tests, EKG, and some other tests for, I can't remember all of them right now. I think one was a Doppler test for your in your neck for arteries and stuff. And anyway, they discovered with the EKG that I had AFib. Now, my AFib was kind of asymptomatic. I didn't have any shortness of breath or any chest pain, but I had experienced that previous to that, some fluttering in my chest, but because it wasn't accompanied by any other symptoms, I had just put it off to a little, muscle spasm or something like that. You can feel a quivering in any muscle in your body, and I wasn't really too worked up about it, but the EKG did indicate it, and the nurse said, you should hang around here for a while and let a cardiologist read this EKG to be sure. And the cardiologist said that, yeah, you're in AFib. And so they confirmed that it was a continuous AFib. I wasn't having episodes of it. It was continuous AFib. So I was referred to a cardiologist, and the cardiologist decided to try cardioinversion, which is an electric shock that they give to the heart to try to shock the heart back into a normal rhythm. And they tried that on a couple of occasions. You go into the hospital for that, and they put you out for that, and it worked very temporarily. And the heart went back into an AFib rhythm. And so they tried that again on another occasion, and it worked temporarily again. And so that cardiologist referred me to another cardiologist, which was a rhythm specialist. And his approach was that since I didn't have any other symptoms, I wasn't didn't have shortness of breath, didn't have chest pains, didn't really have any life, limiting trouble. I could do what I wanted to do. I could go up and down the stairs all right. And his approach was, just keep taking the Eliquis and come back and see me in 6 months, and we'll just see how you do. You're in your early 70s. I think I was 70 or 71 at that point, and kind of like put me on automatic pilot and just kind of go on like that. And I really wasn't too satisfied with that. It just, I started doing some of my own research, and I didn't like as Dr. Kutinsky explained in her presentation, AFib doesn't doesn't offer you a rosy future as far as statistics go in terms of stroke and other heart experiences that you're going to encounter statistically. And so I did my own research and came up with those same statistics. And it enlarges your heart, it remodels your heart, it takes years off your life. And I just didn't like his approach. And so he did offer something that he was kind of vague about, something you could go into the hospital for a chemical treatment that you had to be in the hospital to take. And he was kind of vague on that, and I didn't really care for that too much either. So I read up on this and talked to my wife about it, of course, and she thought that she had a friend who had undergone ablation and it was successful, and she thought it was Michigan Heart Group. And so she contacted her friend, and apparently it was the Michigan Heart Group, and that Dr. Kutinsky was part of that group, and that it was Dr. Kutinsky. And so we contacted that group, and that's how I got to know Dr. Kutinsky. But had I not found Dr. Kutinsky, I was headed off to Cleveland Clinic or Mayo Clinic or wherever they did this, and it was like I was ready. I mean, there's a Creedence Clearwater Revival song where there's a lyric in there where the guy says, hey coach, put me in. I can play center field. I wanted this treatment, so I wasn't apprehensive about it. I thought from what I read that I might be too old for this treatment, but I was 71 and I didn't have any other heart disease that would keep me out. So I was ready for this and wanted it. I even read about the maze approach, and I guess that was something more even advanced that I wouldn't be necessary for me. But the point is, I dug deep into this, and had I not dug into it on my own, I would have been put on automatic pilot by some doctor that figured, well, you're an old timer, just coast on out and take your chances. And that's really a sad statement on a person's life. I mean, you want to, you're healthy otherwise, and you want to extend your life as much as you can and take advantage of what medical science has to offer.
Terry, thank you so much. That was excellent. And that really helped us understand what your experience was. And so to start off the Q&A, I'd actually like to ask you a question that I have in my mind. And let me encourage everyone to be putting in their questions for Dr. Kutinsky and for Terry, and we will get to as many of them as we can. We've had quite a few come in already. But Terry, what would you say, and you've already said some of it, but I'd love for you to elaborate. Those who are considering whether to live with AFib or whether to have a procedure such as the cryoablation and potentially get an implanted heart monitor, what would you say to them to help them sort out their own decision?
Well, there's a lot of heart surgery that's done these days, and I don't really consider this as intrusive as the other kind of heart surgeries that are done. And I mean, I really didn't experience any serious pain afterward, or recovery was really quick. And the loop recorder that was inserted prior to the surgery is really very simple. It's just a tube that's inserted under the skin, and then that monitors your heart performance afterward, and is sent by it records it, and it's sent by, you have a little monitor on your nightstand, which, you know, I mean, we live in such a high-tech world. This thing just records what's going on, and a satellite picks it up, sends it to your doctor's office, so they know if anything's awry, and you don't even have to think about it, and it's awesome. I mean, I don't think it was that intrusive procedure at all.
So
I think it was very, very smooth, very easy. I think there's a lot of other heart procedures that are more intrusive than this. I think this is
Melanie,
yes.
I think that because I get that question a lot. You're you know, kind of, do you move forward and do the ablation, or do you just wait, or what do you wait for? How do you know when to do it? You know, previously we had said to patients like, oh, let's try a medicine. We need to try medicines first and have the medicines fail. And when you do an ablation, when you have no other options, but that is completely changed now. So now we know that AFib is a progressive disease. And if we don't treat it early, our options are significantly less as far as treatment goes. And so I encourage patients, you know, if you have one episode of AFib a year and you treat it with a medicine at the time, or, you know, that's one thing. But when you start having episodes of atrial fibrillation, that's the time to act. You know, you don't want to wait for it to get bad.
Right.
We need to act early, and early treatment is effective treatment. And early treatment is changes the natural history. And
right.
So I encourage patients now, where we used to, you know, kind of wait. We encourage patients now to get treatments sooner.
And so you've answered the first few questions that I had for you, Dr. Kutinsky. So thank you for jumping right in and being proactive about that. What I'm hearing is that often people have fear, and there's no reason to be afraid. Terry, thank you for, you know, confirming for us that it was, you know, a fairly easy procedure. And Dr. Kutinsky, you've addressed a lot of the questions that have come in as to, you know, do you need to take meds for, you know, a long period of time before you consider an ablation, or can you jump straight to an ablation? And so, you know, there are a lot of questions here about that specific thing. What do you advise someone who does want to try meds first? How long should they wait?
So I think trying medicines is very reasonable. You know, if you have symptomatic atrial fibrillation and we find a medication that you tolerate that controls the episodes of atrial fibrillation, I think that that's a very reasonable thing to do.
Okay.
I think that you know, this area of technology is growing. It's always growing and changing, and it's so exciting. And if we can get control for a year or 2 years and you're not having episodes, then that's great. And we're controlling it that way. But really, I would say using medications early is the same as doing ablation early right now. Doing something. Just doing nothing is, I think, a terrible option right now. And I think all of the data, all the research, everything that we have now, we had no options previously. So doing nothing was fine because we had no options anyways. Any options. Now we have really good options, and we have great monitoring options and great treatment options. And so I usually have a low threshold to start medicine, and I have a low threshold to get rid of the medicine and go to ablation.
Right. That's great. So another question that has come in several different flavors, and so I'm going to consolidate that all into one, is do you have to be an AFib when you go in for the ablation itself? And if you don't happen to be an AFib, how do you know that you've gotten all the places that need to be treated?
I think that's a great question. So atrial fibrillation, like we talked about, and I know I talk really fast and I hope people got some of it, but the pulmonary veins are where the atrial fibrillation comes from. And the electrical signals that are in those pulmonary veins are there in patients who have atrial fibrillation, whether they're in atrial fibrillation or not. You have these abnormal signals in the back of your heart. And so when we go in for the ablation, if we're doing cryoablation, let's say, we go in, if you're in a sinus rhythm, that's great. We still see those abnormal electrical signals because they're somewhere they're not supposed to be. And so you do not have to be in atrial fibrillation at the time of the ablation for us to get a wonderful, excellent result.
That is a fantastic answer to a question that we hear all the time in the patient community. So thank you for that. And then there's another question that has come in over and over again in multiple flavors. So let me boil it down to, how do you know if you need to be on an anticoagulant after you have your ablation?
So everyone should be on an anticoagulant during the ablation and after the ablation. For at least 10 to 12 weeks after the ablation, you are at high risk to have a stroke from the ablation because of the procedure itself causing coagulum causing scar tissue. So whenever there's scar in the heart, there's an increased risk of clotting. And so during the ablation, we usually keep you on anticoagulation for 10 to 12 weeks after. And then whether or not you're on anticoagulation is dependent on what your risk factors for stroke are. And so there's a very famous kind of risk score that we use all the time as physicians, and it's called the CHADS-VASC score. So it's CHADS-VASC, and it stands for a bunch of different risk factors that you can have. And we add up that score, and depending on what that score is, that makes us decide whether or not you are on anticoagulation or not. And so that's the first step, is determining what your score is. The second step is deciding whether the ablation was successful or not. So if you have a low score and you have no atrial fibrillation, then we talk about stopping anticoagulation long term. So short term, you're on it, but long term, it's a conversation that you have to have with your physician. And so for Gary, let's say, he has a medium CHADS-VASC score. So we implanted the monitor. So in order for us to take him off of anticoagulation at some point, we need some comfort that he's not having any atrial fibrillation, because his symptoms are not good enough. And so when we don't have symptoms to guide us, the monitor gives us a really good idea. It can tell us that he's not having any atrial fibrillation. So in those patients who have a low risk score, we feel more comfortable stopping anticoagulation in that situation. But again, it's something very individual that patients need to talk to their individual physicians for.
Right. And that is fantastic. And another question that has come in various forms is, does AFib damage the heart? And also, does AFib cause you to die sooner than someone with a healthy heart?
So I think, okay, so the first question was,
does AFib damage the heart?
AFib, theoretically, if atrial fibrillation is rate controlled. So the problem with atrial fibrillation is that you can have heart rates that are very, very, very fast. Mm-hmm. In patients who have heart rates that are very, very, very fast, atrial fibrillation can cause the heart to weaken over time. And so, yeah, it can damage the heart in that way. Atrial fibrillation over time causes fibrosis in the atrium, and that leads to more atrial fibrillation. So that is atrial fibrosis. Mm-hmm. And then when the heart rates are uncontrolled, that causes a cardiomyopathy, which is a weakness of the left ventricle, which is also very serious. Mm-hmm. And then the second part of your question, Melanie?
And so the second part is, do those with AFib die sooner than those with healthy hearts?
Yeah, I think that we know that patients with AFib have more heart failure. obviously have more stroke, and actually do have a higher mortality, which is how we define death, sooner death.
Mm-hmm.
And so, yes, I guess the answer is yes. Yes.
So an extension of that question, does having an ablation and getting out of AFib change that trajectory?
I hope so. Yeah, I think that we have been doing atrial fibrillation ablation now for close to 10 years.
Mm-hmm.
So I think that it's hard for us to determine whether or not it modifies mortality,
Mm-hmm.
right? We have, if you do a 70-year-old, we need to follow them for 20 years or 30 years. So it's hard to say if it's going to change that. We do know it changes the natural history of atrial fibrillation with, the 8 to 10 years data that we have. So yeah, I hope that it would also help with heart failure and help with early mortality as well.
Right. So another question has come in is, what is the relationship between AFib and sleep apnea?
So very, very, very tight relationship. So a lot of times people who have sleep apnea, the way I think about it is any stress on the left heart, any stress on the heart stretches the left atrium, puts you at risk for triggering those fascicles, those abnormal electrical currents. And sleep apnea puts a lot of strain on the heart. And a lot of times we see atrial fibrillation, it starts at night when you're hypoxic or you're not getting adequate oxygen. And again, that puts stress on the heart. A lot of centers, a lot of the busiest centers in the United States will not treat patients with ablation unless the sleep apnea is treated first. And that is a relationship that is very well defined at this time.
Right. So another question is, after the blanking period, how do you determine if the ablation is successful or not?
Love this question. It's a bit of a controversial question, and you might talk to 10 different electrophysiologists and get 10 different answers. So the very first thing we do is determine what your CHADS-VASc is. So if your CHADS-VASc score or your risk for stroke, if that score is a 0 or a 1, so if it's very low, then after 10 to 12 weeks, we take you off anticoagulation, okay? If your CHADS score is 1 or 2, then I usually find a way with my patients to have ongoing monitoring, because we know that after ablation, you may also have atrial fibrillation that's not symptomatic. So you may have had symptoms before the ablation that you don't have after. So we do need some ongoing way of monitoring. So I have patients who wear a monitoring watch. I have patients who do the home telemetry, home telemetry device that you can get at home that tells you whether you're having AFib or not. I have them do it every day. I have them wear the watch, or we do the continuous monitoring like what Terry has, like the loop recorder. And so, but I do think that once you have the ablation, that's not the end of the story. You do need some ongoing evaluation for AFib.
Mm-hmm. Okay.
But we're lucky now, we have all these different options.
Right. So there's one last question here that because we're running out of time. And so I'd like to ask both of you, Dr. Kutinsky and Terry, what is the follow-up typically like for a typical patient? And Terry, what have you had to do as part of your follow-up? Were there modifications in your routines that you had to do as a result of having an ablation, and how long did you have to modify them? So why don't we throw that to Terry first, and then we'll let Dr. Kutinsky tie it all together.
I haven't had any severe modifications, anything. I mean, I'm not diabetic, so I didn't have to do any major diet changes. We eat, my wife and I eat a good diet. We had already been moving away from meat
Mhm.
and we exercise. And so I didn't have to make any major behavioral changes in that respect. Alcohol and tobacco are not part of our diet, so we didn't have to reduce that. I really didn't have to do anything. I was pretty healthy to begin with, and that's one of the sales pitches that I had made to Dr. Kutinsky, that I, please, I'm a good candidate here, for this. Like I said earlier, I thought I was kind of on the older side for this, but otherwise, I mean, I'm lucky that I was healthy.
Yeah.
And one other thing, I was adopted as a child, and I never tracked down any birth parents, so I have no the heredity factor could be playing in here. I don't know. So I might just be lucky on the one hand that I don't have any of the other health issues, but I could have the hereditary issue for the AFib.
Right.
So I really didn't have to do anything special as far as changes.
Okay.
Just make sure that my little monitoring device is plugged in and working, and
Right.
show up for my appointments every so many months.
Right.
I guess that's it, really.
So that sounds like it's very reassuring for others who are considering this to know that it really didn't require a whole lot of changes, even, right after the procedure. So that's great. So
No.
Dr. Kutinsky, if you would be willing to share with us any things that patients should know about after their ablation.
Yeah, so usually, like I said, I right now, the immediate after, most people go home either the same day or the next day. No heavy lifting. That's anything over, 10 pounds for about a week.
Mhm.
Normal activity. We usually see them in the office at 2 weeks and at 6 to 8 weeks. And then we focus on lifestyle, right? We say to patients, try not to drink too much. That's no more than 2 drinks a day, no more than 5 drinks a week. That's kind of what I use. And again, that's the kind of thing you could have 10 different cardiologists give you, their expertise or their ideas on alcohol, but alcohol definitely is a trigger for atrial fibrillation.
Right.
And even after the ablation, I do encourage patients to kind of focus on and practice healthy living, a healthy lifestyle. So moderate, not a lot of alcohol, exercise regularly is an issue. There's some research done by that was published in the New England Journal of Medicine that if you lose 10% of your body weight, it decreases episodes of atrial fibrillation. So keeping your weight down, making sure your sleep apnea is addressed. And then ongoing, like we have a discussion, I always have a discussion about ongoing monitoring. Do you check your pulse every day? Do you have an Apple Watch? Do you have, things like that, so that they know that they don't be surprised if in 10 years the AFib comes back in some form. Just be aware, just be looking out for it, because we just don't know long-term kind of how, you might need a touch-up procedure. And so I do have that conversation with patients. And so living a healthy lifestyle decreases the risk of having recurrence and just improves your cardiac health in general. When you have good cardiac health, the chances of the AFib coming back are less.
So one dimension of that I'd like to ask about, and then we'll wrap it up. We often hear from AFib patients who are competitive athletes or, love to exercise. Their question about how quickly can they go back to that level of athletic performance. So
1 week,
1 week.
5 days.
Okay.
Yeah.
Terrific. Okay. That's fantastic information. So I feel like this has been a presentation, a webinar that has covered so very much today. And so Dr. Kutinsky and Terry, thank you both for excellent presentations
Thank you, Terry.
for sharing their experiences, your experiences in managing atrial fibrillation. And I hope that everyone has a great rest of the day. And thank you all for joining us.
Thank you, Melanie. Thank you.
Thank you.
Thank you.
Thanks, everybody.